exploring the barriers to the access and various aspects of health and rights of the LGBTQIA plus community. But before we start, we'd like to introduce ourselves. Yashika, would you like to go ahead? Amish, if you're available.
Hello, everyone. Hope you all are doing well. And thank you so much to our esteemed judges to be here, panelists to be here. And we are really glad that you made out time for us. At the same time, hello, I'm Amish Mazhari, and I'm in third year of MBBS. And I'm the National Officer for SCORA for this term, along with Yashika.
Hello, everyone. I'm so sorry. My net was not working well. Hi, my name is Yashika. My pronouns are she, her, and I'm the National Officer for Sexual and Reproductive Health and Rights, including HIV and AIDS, along with Amish Mazari. And I'm really grateful to be part of this amazing campaign and organizing it. Over to you, Skoff.
Thank you, Yashika. Good evening, everybody. I am Aradhana Vaghela, currently serving pronouns she, her, currently serving as a National Public Health Officer at MSAI India, along with Shambhavi. Shambhavi.
Good evening, everyone. I'm Shambhavi Verma. I'm a final year MBBS student, and I'm also, along with Aradhana, I'm really sorry. Along with Aradhana, I'm one of the National Public Health Officers for this term. And it is an absolute pleasure to have everybody here today. And we hope that this webinar is an enriching and a wonderful experience for everybody, and we learn and relearn. I think we can go ahead, Sanika, if you're here.
All right. I think we can start then. A little bit about the context of why we decided to hold this particular webinar. A study published in the Mental Health on LGBTQIA plus community in India found that individuals from this community were 3 times more likely to experience depression and anxiety compared to the national average. Yet only a small fraction reported receiving mental health care due to the stigma and lack of services provided to the community. LGBTQI plus individuals also experience higher rates of other mental illness, and limited access to culturally competent and friendly mental health care services is worsening the problem. Thus, to promote the understanding of mental health concerns faced by individuals with diverse sexual and gender identities, and to improve the knowledge of gender-sensitive healthcare, mental healthcare specifically, and to address the barriers to mental healthcare in India, SCOF and SCORA at MSAI have collaborated, and we take great pride in hosting this webinar, which is exploring mental health in the LGBTQI plus community with some of our esteemed guests. We'd like to take this opportunity to introduce our esteemed panel. Shambhavi.
So today we have some amazing panelists here with us. The first of whom is Dr. Kavita Arora. Dr. Arora is a child and adolescent psychiatrist and is the co-founder of Children First India, an organization which provides clinical services, school programs, trainings, developmental interventions, etc. for children and adolescents in the country. She's a gender affirmative practitioner, and she works with transgender youth and adults. Our second panelist for tonight is Dr. Harikirtan Raghuram. Sir is an Associate Director, Health and Equity at Sangat India, and coordinates the Initiative for Health Equity Advocacy and Research. I Hear Sangat, which works with the transgender and disability communities in India and focuses on the intersection of trans identities, health access and equity rights, inclusion, ethics, and the need for reform in health professionals' education, as well as the delivery of health services. Thank you so much, sir and ma'am, for being here today. Aradhana, we can go forward with the rest of the
To introduce our next 2 panelists, we have Kenny Bhatia, pronounced she, they, who holds a BA in English Literature from Durham University and an MA in Applied Theatre, Drama in Social, Educational and Community Contexts from Goldsmiths, University of London. Their work is centered at the intersection of arts, education, and social justice, and their research explores these through body, space, and language, especially using practice-based research. In their free time, they choose to read, bake, and sing to themselves. Dr. Prachi Patel, our final panelist, pronouns she, her, is an alumna of Lady Hardinge Medical College and has been an active member of MSAI. If some of you have been following our organization for a while, you would have seen her around. Previously having served as a GenSec of the MSAI Bioethics Unit. As an out and proud member of the queer community, she has been an integral part of her college's student advocacy group, Queerentia LHMC, which advocates for health equity and LGBTQIA+ inclusive healthcare. Thank you so much, Kenny and Dr. Prachi, for joining us. And now that the introductions are behind us, without any further ado, we're just going to launch into the burning questions that we have for this webinar. Shambhavi, would you like to go ahead?
So thank you, everybody. I hope we can turn on our cameras for this part so that we can interact with each other. I think we'll wait for just 30 seconds so that all of the participants can, turn on their cameras. Okay, I see faces. Okay, so let's start with the question. So our first question for the evening is posed to Dr. Kavita Arora and Dr. Harpreet and Raghuram. So, sir and ma'am, it was only in 2018 that Section 377 was abolished in India, legitimizing the reality of the life and experiences of people from the community. It's been over 5 years, but we see, that the stigma that surrounds people from the community, it persists in a major part of the country. And a lot of research suggests that individuals from the community are much, at a much greater risk for developing mental health issues in their lives as compared to the rest of society. So we see that, this inherent stigma, it spills over into the lives of people. So could you shed some light on exactly why we need to be talking about being more inclusive in our mental health care delivery? And what unique life experiences that you believe make people from the community a vulnerable group with respect to mental health? So Dr. Arora, if you'd like to go first.
Sure, I'll try. It's a wide spectrum of a question, but thank you first of all for inviting me here. And like I said in the comments, I love the backgrounds. It's great to see on the screen these little windows. And Prachi, I'm also an alumnus of Lady Harding, so it's good to see you here. A long time ago, though. I passed out way back. But yeah, so I'm also queer and out, and so I just wanted to qualify that. I think one of the things that I see, which is very obvious, is we've all grown up, like people like me, we've grown up knowing that homosexuality and other aspects of LGBTQIA population are seen as criminal, as recently as 2018. So when you grow up knowing that the social story around something is that of criminality, there is inherently a story inside each one of us that willy-nilly finds its way to sit inside our mind spaces. And 4 to 5 years ago, so children who are now going to be born and grow up in today's world in India, where post the reading down of 377, will have a very different life, we hope. So of course, there is social stigma, which has not necessarily gone away just because of policy change, but at least the legal part of saying, if you identify as an LGBTQIA individual, you are not a criminal. And therefore, whatever you do in your choices is not going to land you up in jail. So I think for doctors and for mental health professionals to understand that the young people coming to you have grown up in that time. So it is very different from saying, what will happen today versus what did you grow up with? So that's one part that I think everybody needs to remember. And then what does this mean? What kind of stresses have people gone through? So what will they present with? So when you have kept a part of your identity secret for a very long time, sometimes even from yourself, but specifically you are hyper vigilant to see who will accept me, whom can I come out to? So the entire effort of coming out has been left to the individual. Should I? Is this doctor safe? Can I tell them? Or should I not? And how do you tell? whether this doctor is safe, whether this mental health practitioner is safe. So I think for all practitioners to remember that this is the history, and what is often labeled as minority stress is something that you will have to look out for. Not wait for it to unfold, but to assume that an individual coming to you who is LGBTQIA has the high possibility of minority stress. That doesn't necessarily mean that they are only vulnerable. It may also mean that they have a lot of resilience because they've actually encountered this stress for a long period of time, and they've actually created coping mechanisms. They may not have needed to, they ought not to have needed to, but they've got to, so they have. So there is also an equal amount of resilience that people have. So when we talk about prevalence of mental health conditions and what to look out for, there are very few studies in India, and although you've quoted a few, and you've quoted a recent one, the bias that you will see is these studies would only be able to tell people who have come out. There is a very large percentage of people who are yet to be out, who don't find the safety to be able to claim the space of being a lesbian or a transgender person. So prevalence I think it is actually really underrated. And we don't know what the prevalence is. And if we don't know the prevalence of a particular subset of population, then it is very difficult to ascertain the prevalence of mental health conditions within that population as well. So that's an inherent problem that we will have. It is an invisible, there's a large part under the tip of the iceberg that you may not know. So keeping it in your mind space as practitioners when you enter the space, that there is nothing that will show on the face of the person when you encounter them, but to keep respect of all, regardless of gender and sexual orientation, is something that we must hold in our own mind spaces. And for that, one of the biggest things that I feel we need to look at is forming spaces for reflection on our own practices and critique in our own practices. To be able to question ourselves, am I doing this? Am I not doing this? Am I doing something right? Do I need to learn more about it? Is there somebody else who's doing this? Are there ways to do this? Is my waiting room safe? All those things. And I think those things as practitioners, as medical students, and then medical practitioners would become very important. Looking out for trauma which is unspoken of, stress that is coming from decision-making on an everyday basis. Should I say this? Should I not? And sometimes very unique presentations. Because how do you reveal to someone that I'm questioning my gender? And I think the final thing before I stop, I'll say is that there is a very thin line between pathologizing the LGBTQIA population by the medical world versus not. And I think that's something that the onus is on the medical community now. For a long period of time, homosexuality, transsexualism, transgender have all been classified as disorders, psychiatric disorders. It's only very recently that it's been noted and acknowledged that these are not medical disorders. Gender is owned by the person. Sexual orientation is a very natural phenomenon. And therefore, these have been chucked out of classificatory systems. They still find their way into sexual and reproductive health, but the comorbid mental health conditions still exist. But by itself, having a preference for a particular sexual orientation or gender is no longer seen as a disorder or pathology. However, you're sitting in the medical world and people come to you usually, or will come to you usually, for you to detect pathology and abnormality. So sometimes it's very difficult to keep that hat away but you should be aware of it. I'll stop now and let Harikirtan and other panelists talk.
Thank you so much, Dr. Kavita, for that very deep appeal to all of us to reflect on our own practices. Thank you so much to the MSAI for organizing this. I'm very excited to be here and to speak on such an important topic. And Dr. Kavita spoke about how for a long time, being homosexual, being someone who identifies as queer or LGBTQIA was considered a pathology, is considered something as abnormal. And because of that, there were a lot of negative experiences that they were having. And as doctors, I think our job is to heal, primary job. But unfortunately, when it comes to the LGBTQIA plus community, doctors have been a source of harm for many people. And this is, I think, one of the important things for us to recognize, this, I think, dark history of healthcare, and including in mental health care, where parents often bring their queer children or children who seem queer to psychiatrists, psychologists, doctors, non-allopathic doctors also, saying that, can you fix my child? And doctors would do that. Doctors would collude with parents, and still in many places that is still happening. And we keep hearing stories of that. This is called as conversion therapy or sexual orientation change efforts or gender identity change efforts. So while Dr. Kavita spoke about the more of the human rights aspect to the right to live authentically as a queer person, I would now ask you to look at the legal aspect, which is that now it's no longer legal to do this. And since the now Johar Singh judgment of 2018 that read down Section 377, there have been a lot of developments. 2018, the Indian Psychiatric Society released a statement that saying that homosexuality is a normal variation. 2019, the Transgender Persons' Rights Act came out, recognizing the rights of transgender person and the right against non-discrimination within healthcare settings. And it is a punishable offense if doctors are engaging in discrimination of transgender persons. Subsequently, there has been several efforts towards revising the medical curriculum. As Dr. Kavita mentioned, medical curriculum explicitly used to state trans and homosexual identities as pathologies or criminal offenses, as fetishes, and all that is now slowly being changed. NMC has released a directive in 2022, including saying that conversion therapy is a professional misconduct. So as doctors, that's something we need to know, that even if we don't fully understand what it means to be queer, it is not something it is something we should accept and not try to collude with parents. And maybe somebody who's queer themselves may also think that I am abnormal, there's something wrong with me, because when you're living so many years in a world that is telling you that being queer is wrong, being queer is abnormal, something to be fixed, then slowly you also start thinking like that, although that is completely untrue. So that now we have rules against that. And that is another reason why, as doctors, we should be practicing care. So coming back to my original point, that as doctors, our primary job is to heal, and all of us have come to this profession to heal. But unfortunately, harm continues to take place in clinics, in hospitals, in front of doctors, because of doctors. It may be extreme versions of conversion therapy, forced conversion therapy, but it could also be something subtle as laughing about a queer person when somebody walks into a clinic, making jokes about them, staring at them weirdly, asking weird questions. A lot of participants in our research study have told us about intrusive questions about how do you do it, where do you put it, and questions unnecessary that for that particular clinical encounter. We need to stop this harm within healthcare setting if we have to make any progress towards making healthcare inclusive. Thank you.
Thank you so much, Dr. Kavita and Dr. Harikirtan. I love how we've covered such a range of topics, right? From the evolution of identities to the changed social cultural scenarios. And I think one thing that all of us can take away from this is we must stop pathologizing and we must look forward towards being more inclusive. And in continuation of a lot of what has been already discussed, I'd like to move on to our next panelists and address a few questions to them. I remember a friend of mine from the community talking about the very complicated relation with psychiatrists. And in the history of science, like it has been mentioned by both our panelists previously, the medicine has adopted a very discriminatory, sometimes abusive attitude towards the treatment of queer people, diagnosing their identities, as has been mentioned, as pathologies and disrespecting their rights. Could you, Kenny and Dr. Prachi, could you please talk a bit more about the history of healthcare and the community, and also mention whether this attitude continues to predominate, especially from your context as queer people or individuals from the community who have lived experience? Kenny, would you like to go first?
Okay. So couple of things with the psychiatric thing.
I'm so sorry to interrupt, Kenny. You're not very audible.
Is it better?
A little bit, yes.
Little bit. Let me try once again. Oh, is this better?
Perfect.
Yeah.
Works.
Okay. Where to begin? Speaking from my own personal experiences, when I've been to a psychiatrist, and I've told them that I come from a queer and trans side, just to vet them out. That's one of my first things, just to like vet them out. Can this person even help me out? Let's see. And this person was recommended to me by my physician. And this guy goes like, "Oh yeah, I write medical certificates for trans people so that they can, undergo the sex affirmative surgery, gender affirmative surgery, whichever one." And the guy does not understand queerness or transness at all. This person writing these certificates for trans people is downright scary. It's absolutely scary. I've had other experiences where I've heard of these, not personally gone through, but psychologists have violated privacy, confidentiality, and gone to the parents to reveal the identity of their client, and then struck the chord of abuse within that household. What I think is fundamentally going wrong in that is the top-down approach. That what is happening is, this doctor, I am the top, and I'm here to fix the patient, or I know more than the patient. I know more than the client. Firstly, treating them as a patient is in itself the first thing, where the client starts to take the doctor's word as the holy grail of everything. That is where I think we make the first mistake. Because then what happens? Oh, but this psychologist told me that just to make my parents happy, just to live an easier life, I should go and marry a girl. And that is where we begin to see downfall. That is where we begin to see even more mental health issues. That's where we begin to see more suicidality. And this is what I'm seeing, what I have seen through peer support groups, through peer support provision in individually. So what I would say, this psychiatry also means drugs, also means medicines. And who takes those medicines? Who has access to those medicines? Firstly, poverty cannot be separated from queerness and transness. Those are one of the first things. If you have access to a lot of money, you are sorted. You have a lot of access. You can't live in India. You will go abroad where you have like rights to being queer, to getting married, and you will go live a free life. What about those who don't? What about trans people who do not have access to essential HRT, to hormone replacement therapy, who do not have access to gender affirmative surgery? What about those who simply do not have access to therapy? Which is why groups like Safe Access have started individual therapy, peer support provision, peer support work, where individuals collaborate and work work individually with people who reach out to us, so that queer people are placed with queer people and trans people to understand each other better. But what I think fundamentally needs to change is this relationship between the doctor and the client, because that is where things start to go awry. When the person comes in and you're like, right, I need to help this person out, that help word is the wrong word. I need to work with this person. I think that is the first attitude where things can change, and where I have not seen it happen as yet. Still trying to see that happen.
Right. Thank you so much, Kelly. Dr. Prachi, would you like to take it up from there?
Yeah. First of all, hello everybody. I'm really elated to be here. Hello Kavita ma'am. Hello Hari Kirtan sir. Hi Kenny. I've had the pleasure of having Kavita ma'am speak at a gender affirmative healthcare campaign a few years ago, and I'm so happy to see ma'am again. It is lovely being here, seeing everybody. Kenny, that was actually a great and a much needed approach that you've put in front of us. I think a lot of people that face these problems are all of our patients, all of our future patients for that matter, and legislative homophobia. If we talk about before the decriminalization of Section 377 in India, legislative homophobia was a very direct extension of British colonial rule. And for a very long time, this system has existed and it has laid the foundation of healthcare system in India. It was established in 1864. So in terms of how far we've moved, we haven't at all, because we are still working on the ideals that were established back then. It has been more than 1,000 years. And so to speak, the world has really moved forward, but not quite enough. Now, I'd like to speak on this question as a physician's perspective. We understand that after decriminalization of this act, the Indian Psychiatric Society actually issued a statement by the end of 2018 that stated their approval and to cease all forms of treatment therapies such as behavioral or conversion therapies, averse conditioning, hypnotherapy, pharmacotherapy, ECT, everything that is directed towards reversing an individual's sexual orientation. They were supposed to be erroneous, based on the premise that non-heterosexual orientation is a disease and it has absolutely not been proven to succeed in reversing their orientations as well in any manner. And it was directly following the legislative abrogation of the same. But like Kavita ma'am very aptly mentioned, social change will always follow legislative changes. And for people who have accepted and internalized this belief that existed from the system established in 1864, now to put it very lightly, people who are double our ages, people who teach us subjects, people who are regarded as experts in this field and who actually are being looked up to as patients, they still believe that they have internalized this belief for so long that they cannot just undo it and unlearn it in a single day. Medicine is not just about treating. It is, we learn so much from our patients every single day, and I think everyone else would agree with me in the same aspect. And even though it has been a learning aspect in all of the ways, but there is a lot to change, absolutely. Now, to understand that mental health is actually, it has to be brought upon as a very holistic and an intersectional approach. And it is a collective effort of our society. So inclusive education does not just extend to doctors or to medical students. It has to be started from a very young age, from childhood itself, for adolescents to understand and to remove all sorts of harassment that happens at very young ages too. It's our language as well that matters a lot when we interact with patients, considering that the traditional approach to a patient was always a very paternalistic one, wherein, like Kenny rightly mentioned, a doctor was supposed to be, somehow higher up on the hierarchy, and patients would look up to them as a god figure or a father figure. But we've seen changes and trends over the years. There have been very consumeristic patients as well. There have been tokenistic patients as well, but we are now moving towards a very mutualistic approach. In the gynae OPD, we have this very beautiful thing called the cafeteria approach, wherein we put a lot of options to the patients and we ask them to choose. Now, this cafeteria approach was actually very specifically for contraception, but this is how we like to approach our patients in today's world, wherein we give them options and we let them choose whatever works for them. And that is how modern healthcare is evolving. But there is always a gap between traditional medicine and modern medicine, and it continues to evolve. So the change is coming, yes, but for the most of us who like to go towards the experts and people who are know-it-alls and all of the others, it is yet a very difficult territory to go into, and to there are a lot of egos clashing, a lot of well, I think that part is self-explanatory. So that was my take on that. Thank you so much.
Thank you so much, Dr. Prachi. I think, elaborating on what we've already discussed, our next question sort of focuses on, healthcare systems. So, Kenny has mentioned how financial access and financial barriers are a very important, problem that a lot of people face, and that's what stops people from accessing healthcare. And Dr. Prachi spoke about how, we're now evolving towards a more mutualistic, medical system. So I think when we talk about healthcare systems and healthcare delivery, we'd like to ask the question about, what are the current barriers that we face at a grassroots level that people from the community experience? And I think Dr. Harikirtan, if you'd like to, shed some light on that.
Sure, thanks, Shambhavi. In terms of barriers to access to healthcare, I will speak primarily from one of the studies that we recently completed. It was a qualitative study looking at experiences in access to healthcare among transgender persons. And a lot of those experiences are similar to other people in the community as well. So broadly, what we saw is that one is challenges in access to healthcare start from before entering the health system itself. And that starts from a lot of past history of negative experiences that somebody from the queer community themselves might have faced, or someone else from the queer community might have faced, because of which there's a lot of fear, a lot of hesitation to access healthcare, which means that a lot of people then delay or postpone going to health centers. When it's an emergency, they wait until it becomes a real emergency before coming. And a lot of participants spoke about that. Second is, as Kenny rightly mentioned, you cannot speak about the queer community and trans community without speaking about poverty. There's a lot of poverty, lack of education, which means that access to healthcare is affected by all these other factors also. Third is in terms of illegal identity cards and insurance. A lot of people, especially from the trans community, may not, they would have changed their name, would have a different identity, gender identity. But because of the challenges in getting a legal identity in your own gender rather than your sex assigned at birth, that means that is creating another barrier in accessing healthcare. Now, once you enter the health system, barriers start from right at the entrance of your hospital. Security guards who might say, oh, this is not for you, go away from here, are also stories shared by people from the trans community. Then you go to the registration form, invariably you see that the form says only male and female. Queues are often in binary, where in places where a gender binary is not even required. Toilets are in the binary. Participants have shared, a trans woman shared about how when she's not comfortable going to the male toilet, and when she goes to the female toilet, her voice gives it away. So there also it's not comfortable for her. And a lot of participants share that they keep holding their pee the entire day because there's no choice. And then finally, when you get to meet the doctor, then again, a host of negative experiences there. Finding a doctor who understands or knows about queer identities itself is difficult. And then the harm that happens with the doctor in terms of intrusive questions, experiences of abuse, including sexual abuse, financial abuse, conversion therapy, doctors thinking that they know better, whether it is about who can go for gender affirming therapies, as Kenny mentioned, or who should not go for gender affirming therapies. And then, and because of all this, there's a lot of impact that people have, including in terms of mental health. So overall, there are multiple levels of barriers, but these are all barriers happening in addition to the burden of health problems that the community have, again, because of systemic problems. So it's actually a double burden. You have a higher risk of different health problems, including mental health problems, but at the same time, you are having a poorer access to seek care for the same. Thank you.
Thank you so much, sir, for that. Dr. Prachi, if you'd like to add something. Just, about healthcare barriers at the grassroots level, something that maybe you've seen in your experience as a physician in the OPDs.
I think first of all, there is a very poor knowledge of SOGS, that is sexual orientation, gender identities and expressions and sexual characteristics within the community, especially in the, older healthcare workers, healthcare providers. And there is a very, I would say, poor practice of assumption amongst the community, and not just towards the patients as well. They don't necessarily respect the individual's self-expression, including their pronouns. A lot of people tend to completely avoid, their preferred pronouns even after the disclosure by the patient. There are, in addition to the social stigma that actually prevails, there are a lot of, unfortunately, personal prejudices, which are very largely fueled by the very legislative system, again, going back to the same thing, that governs them, and the very healthcare system that, uproots from that system. And in some even more unfortunate cases, there are religious beliefs that often fall in the way of adequate healthcare delivery. But most importantly, even if individuals were to educate themselves and put all of their prejudices aside, fight the system, they don't know how to build a different system, or how to change things for the better for some people. Because even if one individual, let's say I in a setting were to change the way that doctors address these things, address their patients, the hospital necessarily won't be very receptive towards the same. The patients, the staff would not necessarily be very receptive towards the same. Infrastructure cannot be built in a day, and the mindsets of people, it might take years to change. So even working towards a more gender inclusive healthcare system will take a collective effort. And discrimination, which is discrimination is more likely to be towards trans, non-binary and gender fluid individuals. Most of these who let alone doctors, but even people like you and me, on the roads or going somewhere or encountering them somewhere, would not know how to address. So there is such a blatant lack of conversation towards things that people consider unnecessary. There is an elephant in the room, and people still want to shy away from them or don't want to discuss this. It is such a difficult conversation even to have with our friends, because they might judge us. Somebody makes a homophobic joke, and we just tend to avoid it, and or maybe even laugh it away. There is it really comes from the grassroots level. It's with our parents, it's with our friends, it's with our co-workers. As a person, in fact, I like to wear this badge a lot. I used to wear it in my OPDs. I once wore it in my emergency. I've had some seniors and residents, call me out that why are you wearing this? Are you like one of them? Or Pride Month was in June. Why are you still doing all of this? And I'm like, well, I'm an ally. So like, wo to main bhi hoon. I mean, that I am also, she's also. Then why are you something special or what? So even when we try and open up this conversation, they would be uninterested or, just very quick to point out, oh, you might be different or, if that's something abnormal. So it's an existing stigma and it is difficult to crack. So I think those constitute the barriers even in a healthcare system.
I would just like to add in here that we would just like to give a gentle reminder to all of you and to me as well that this is a complete safe space. And yeah, since we are talking about a lot of sensitive topic and a lot of sensitive subjects here, if you feel the need to take that sip of water, to take that pause, kindly feel free to do so. You can turn off your camera in that moment and feel that and come back whenever you want to. Thank you so much.
Thank you for that, Amish. And thank you for that, Dr. Prachi and Dr. Harikesa. So our next question, delves a little bit more towards, a more patient-specific approach. I understand that, the term patient, as Dr. Kavita has added in the chat, is a very, very passive term. But since we do use it in the healthcare, spectra across all providers, it's a term that we we'd like to bring it here for this specific question that, a lot of our audience members here attending the session are majorly here to understand how we can become better providers for for individuals who come from the community as our patients specifically. So how do we adopt gender sensitive approaches and, specific patient specific approaches to mental healthcare delivery, and what changes do you see as an individual or as a physician practicing, and I think I'd like to address this question first to Kenny. As an individual from the community, what changes do you want that should be made as of this moment?
The client is the expert on their identity. That's the first thing that the person needs to understand. You are not the expert. Every identity has a ton of experiences which you will not be able to understand, which any other person will not be able to understand without asking. So ask questions. That's literally the first thing that even I had to learn as a person who was providing peer support. The first thing, even as peer support providers, as as workers in the social justice sector, as practitioners of any kind of support or SOS practices, we need to remember the person we're talking to is the expert on their own identity. Whether they say, okay, they are bisexual, you don't interpret that for them. They know what it is. That is my first understanding of what is better health, what is better practice, of how to improve the practice itself. Second would be, it's just as basic as report and blacklist those psychiatrists who are still practicing conversion therapy. The head of the Gujarat Medical Health Association is one of the richest psychiatrists in the city where I live, and practices conversion therapy. And that is where power comes into critical question, because that person holds an immense amount of power. So if that person is held at an authority, that means that that person needs to be countered with such a large number of people that the authority itself is coming into question and is stumbling upon itself. Which is why a report, blacklist, create resources, and create resources so that there can be a pool of pro bono services that can be offered, where poverty is a big barrier in access to those mental health services. Also, a lot of psychologists also say psychiatry is banned for us. Like if you come to us, we will take you off medication. Not happening. People have different needs. Psychology and psychiatry need to sort out their own relationship first before making a judgment on the behalf of the client themselves. Some of us need both. Some of us are put on medication because we've been on SOS situations, in SOS situations. Some of us get away from that over time, and that's great because the more the drugs in our system, the more messed up we get. We fully understand, but that doesn't mean meds are always bad. So, sorting out the relationship between psychology and psychiatry is supremely important to get good mental health care and just as an improvement in practice. So, yeah, that's pretty much.
Thank you so much for that, Kenny. And I think here, the point that you've raised about the relationship, the complicated relationship between psychiatry and psychology. And amongst us, we have a psychiatrist, and I would love to direct this question towards Dr. Arora. Ma'am, how does, this divide between psychiatry and psychology, and how, people often, people from the community would be oscillating between one practitioner and the other. How does this affect, the quality of healthcare that people get?
In a single word, very badly. But I don't think it is just between psychology and psychiatry. I think even in the disciplines within medicine, between pediatricians and psychiatrists, between the internal medicine person and psychiatry, between the surgeon and the internal medicine person. I think we are taught in Western medicine to look at one aspect and deep dive into it. Whereas the client who's coming to you is a whole person and does not just have an eye or an ear or a heart. They have everything else too. And oftentimes, I think in medicine now, especially in the way that we are taught in our educational institutions, medicine has become about going to the micro level without zooming out. So super specialization, 126 subspecialties. One person. Yeah. And out of these 126 subspecialties, one is psychiatry. So all the invisible parts of you, all the richness that you hold inside in your mind, the rest of it is 125. Alongside that is this psychology, where people don't know what the difference is between a psychiatrist and a psychologist. There is a hierarchy, psychologists in their qualifications versus doctors in their qualifications. There is confusion. However, I must say that in the last 25 years of my practice, there is a very welcome change. Psychology has really come up. There is an explosion. Therapy, psychology, counseling is something that people are starting to recognize as something which must flourish. Mental health is something that people are talking about. It is getting owned by more than just psychiatrists, more than just the biomedical model. And it is in our education system and the stories we tell ourselves about what is needed more or what is needed less, what is valued more, that we start making these fragments, I think. This has not been made by the community or the clients. When you're receiving someone, whether it's a child who's 4 or a family, they are looking for a solution and a healing of whatever they are coming with. And oftentimes now, I think in medicine, what happens is you come for an eye checkup, you end up going to a diabetologist. Then the endocrine specialist tells you that you might need to go to a podiatrist or a surgeon because you have something on your foot. So that single person who's diabetic is actually now going across 5-6 different medical professionals. उसके बाद psychiatrist के पास तो आना ही पड़ेगा. Navigating 7 different medical professionals who often don't agree with each other because all of them are experts. All of us are bloody experts all the time. You don't know the leg, I know the eye more. And, I own this patient more. Please admit him under me. And then ultimately, चलो और कुछ नहीं समझ में आ रहा, सारी investigations कर ली, चलो psychiatry एक referral कर लेते हैं. That is, if we are not careful, that is the practice of medicine. So I've deviated from the psychology, psychiatry to first say, let me point fingers right first this way, and then we look at psychology. But it's very important for us to reflect on the practices that we are starting to give value to and give weightage to, because the more super specialized you become, the more your worth increases in the social system. But is the worth increasing for you in the social system, or is the worth increasing to the person you're helping? That is what you've got to figure out. And as students who are growing up, these are the critical questions you have to keep asking yourselves. We didn't have forums like you have. Nobody asks us these questions. I've learned it 10, 15, 20 years later by reflective practice. And because I work with young people, 0 to 25 age group, they ask me these questions. What are you doing, Dr. K? Yeah, so I am blessed because I work with a very, very big team of psychologists. And this is by intention. We're a team of total of 70, out of which 50 are psychologists and 5 psychiatrists. So I'm surrounded by them and they teach a lot. I don't see that as a profession that is either ancillary or less than. They have skills which I don't have and will never have. If we can collaborate, then the client is helped. So I think somewhere, if we are able to, and what we were talking about barriers, if you flip it, what will help? The barriers have been created by so many different things, by the social structures that come alongside. What will help? What can each one of you do? Because sometimes when you think hospital system, big people, we are just entering, we are medical students, what will we do? The government has to take care of the barriers. I am no one. But I think I always ask everyone, because this is the question I ask myself, what can I do to make a difference? And I think that question you have to, is the barrier here in each one of us? And if there is a barrier here, you are responsible for that. The government is not responsible for this barrier. So let's take care of this one. Let's reflect on our own practices. Let's figure out what is my barrier. I feel uncomfortable because I don't know. This is many medical students. I don't know how to address someone who has come out as queer. So I will not address them so that I don't go wrong. Now, here is someone who's taken the courage to come out, and you're afraid that you will go wrong. Look at the fear they might hold. आपका डर तो इतना है, उनका डर देखिए ना. और उन्होंने उस डर को पार करके माउंटेन ड्यू पी के आपको बताया है. अब आप डर रहे हो कि मैं कुछ गलत, अरे बोल दो गलत, हाउ डज इट मैटर? बट बात तो करो, कनेक्ट तो करो, पूछ लो उनसे respectfully from a position of curiosity, not one of expertise. So the barriers are here. Inclusion and exclusion does not happen because of a ramp that has been put. Inclusion and exclusion happens here. Inclusion happens if you are attempting to call in rather than wait for someone to come out. Is it up to the individual always to suss out the system and say, I'm coming out, will I be safe? Or can we as doctors call them in, invite them in to say, this is a welcoming space. Do not have a barrier. आपके waiting area में, in any hospital, किस तरीके के poster लगे हुए होते हैं? Is there anybody who's binary in those posters? Anyone who's non-binary, sorry. Are there any heroes, any stories which do not say he and she? How is that welcoming? And it's a very small thing to be able to have, like Prachi says, a badge or a flag or this. Why did I comment in the beginning on all these backgrounds that you guys have? It states something. Can we not have a wall in each hospital that just has the rainbow with the intention? Can each one of us not carry a rainbow badge? These are things we can do to make a difference. So that's up to us. It's here. Barrier is not a physical barrier. The barrier is here. And whether it is barrier of inadequacy, unawareness, being caught as foolish, being caught as in the wrong, we've all lived through those. It's up to us. Are we going to get over our barriers to be able to go forward? And traditionally, historically, this is a population that has been, it's really been discriminated against. Are we able to recognize and apologize and say, you know, we've done this as the medical community, we own up to it? Like when Kenny was speaking, I wanted to apologize, like, yaar, kitta bura psychiatrist tha. Sorry, yaar, Kenny. That was my first reaction, that I wish you had, you know, met someone who was able to see and understand what they're doing. They may have been unintentional about it, but the impact and the trauma is still there. So I think what I'm trying to tell each one of us here is, you cannot claim unintentionality as your cover. Please read up. Please figure out. If you don't have an answer, find out an answer. Google it. Our time, we didn't have the internet. We had to go ask. We were dependent. Google it, man. There's so much out there. Thank you.
Thank you so much for those beautiful, beautiful words, Dr. Kavita. And you've actually answered the very last question that we have. You know, we had this very nice, elaborate question to just know what we as doctors who hope to practice equitable and gender-sensitive mental health delivery, what we need to do in order to make our practice more rooted in empathy and understanding and compassion towards all people, regardless of their gender and their sexual orientation. And you've covered it so beautifully, ma'am, but I'd like to invite Dr. Hariketan and Dr. Prachi also to share their 2 cents on how we can become more inclusive and more empathetic healthcare practitioners. Dr. Hariketan.
Thanks, Aradhana. I think I want to share something that I've been learning in my own journey in working with the queer community. So I think as a society, we've been trying to enforce these norms around gender and sexuality, saying that somebody who's male at birth should dress like this, speak like this, identify as a man. Same thing with somebody who's female at birth. What I'm learning is that this system actually doesn't work for anybody. Nobody can fit into those norms, expectations at all places, at all times, at all stages in their life. Nobody is actually doing that. We are all breaking those norms on a daily basis. Many of you have broken those norms to have in coming here, in taking up these positions, in taking up these spaces. So what I've learned in my own journey towards becoming more affirming, more sensitive, I think one main thing we can do is to reflect on our own identities. Reflect on, when did I think I am a man, or I am a woman, or I am a non-binary person? What makes me that? When was the first time I thought, oh, I'm a man now? And why? And to understand and reflect and to identify that queerness within us. Because this system is not working for anybody. Maybe a small minority who get to have those privileges, but for the majority, this patriarchal, cis, het, bi-normative system is not working, which means that any action that we can take to increase the freedom of somebody from the LGBTQIA plus community is going to increase the freedom of all. Thank you.
Thank you so much, Dr. Hariketan. Dr. Prachi?
Yes, I'd like to just add on to some points that we can as individuals do to create a more gender inclusive environment, especially in terms of mental health. So as medical practitioners, I think, like Hari sir very beautifully said, we should ask ourselves, and we need to actually we need to change our outlook, and more importantly our language towards people. So nobody in the queer community as a representative has ever been, has ever asked to be treated like a special person. We've been asked to be treated humanely, and it is, now if you were to stand in the shoes of a medical practitioner, why don't we treat everybody as if they could be from the queer community? So we could be gender neutral to everyone, and not just people that we might, suspect or assume to be different. So instead of MSAI, especially when I was working here, we had this practice of obliterating sir or ma'am from males, and we used to write gender neutral terms. I've learned to whomsoever it may concern, maybe, more gender neutral and more more effective towards, a gender inclusive society than dear sir or dear ma'am. We can use alternate terms instead of women, for example, people with vagina, or people who menstruate. I understand that for older people and for some people it may be difficult to understand that trans men can menstruate and they have pregnancies too, but we can use people with uteruses, or another thing that I think needs to be changed is medical documentation. Like it was very rightly mentioned, when people find male and female and nothing else. So instead of, our documentation, instead of having sex male or female, we can just write sex assigned at birth, which is, to be honest, based on genitalia. When we're born, we just we just look at the baby whether they have something that resembles a male. If they have a penis, they're just called boys, and if they have vaginas, they're called females or girls. So we can just write sex assigned at birth and then leave the gender blank for the individuals to determine when they grow up. So I think this was a concept that was introduced by Athi, to have birth certificates like these to document only the assigned at birth sex and to leave the gender blank. I think I'll share the link of this in the chat after this. And additionally, non-judgmental behavior and just a simple act of apology has a lot of power, more than we can imagine. We're humans, we all make mistakes, be it doctors, be it patients, be it people in power. Just apologizing and asking what we can do to be better has a lot of power. And we all can go wrong, we all can misgender people, we all can assume, because it's years and years of conditioning. As a person from queer society, from the queer society, I tend to misgender people sometimes, and I simply apologize, because there is nothing else and nothing more powerful than to accept that we are in the wrong. And coming from a person who has that power and who has that stature can make a lot more difference than any other person doing it. Then gender inclusive healthcare should be an essential part of the competency curriculum in medical literature. And I understand that most of our audience is medical students. AtCom is actually a beautiful place to start the conversation. We believe that it should be made an essential part of that curriculum as well. Then, having very good anti-discrimination and anti-harassment policies in organizations. I've worked with MSAI, so I know that we have that. Just simple statements like we provide healthcare to people of all genders on the spectrum, and setting up special helplines or special communication channels for those people, it can have a very good impact on the overall system. I'd like to share that when I was in Harding, we had established Querencia. as we aimed to establish basically a safe space wherein people of all genders and people on the spectrum and people even who were not on the spectrum, not willing to come out, people just wanting to have a conversation could gather and just start something. We were met with a lot of resistance from the administration, I'll tell you. People just outright asking us, oh, are you one of them? Or do you have one of them? Or do you have one of those trans people? Why do you want to do this? And you're just perfectly good girls. Why do you want to, delve into that? We had to establish our anonymity so much and work as a group just so that, the voice of a community could be maintained. But I'll tell you that efforts help, and we had put a lot of effort into it, and we saw the results because after a few years in Kalavati, uh, toilets for transgenders and disabled and inclusive toilets were also started to being established. Adolescent clinics used to counsel people specifically whether or not they were in the need for gender inclusive healthcare. So change really starts from the bottom, and kids, adolescents, students, and then everybody else. I believe that this generation, which the Gen Z that we very fondly like to call ourselves, we have been blessed with a lot of resources. Like ma'am beautifully said कि उनके ज़माने में पूछना पड़ता था, इधर उधर जाना पड़ता था. People might not know, people might know, किसी को भी कुछ भी होता था पता. But we have so much information and so much of resources on our hands. It's easier to. We have our challenges. Yes, I'm not saying that things are easier for us, but we can make changes. We can make waves in the ocean in ways that were not possible at around 20 years ago or something. So yes, those are my 2 cents on the conversation, and handing over to MSAI. Thank you.
Thank you so much, Dr. Prachi. And I believe from discussing the history of pathologizing the community to their journey of empowerment, from society, law and policies to medicine and health systems, from dismantling colonization to revamping education, and even reimagining the existing doctor-patient relationship, this webinar has literally covered everything. And having heard such transformative ideas from the medical community, members, representatives from the medical community, I would like to hear one final remark from the key stakeholder that we have amongst us, from the other side of the table. Kenny, would you like to share any final remarks that you have about the future you'd like to see in our audience members as inclusive healthcare practitioners?
Firstly, I don't think I'm the only stakeholder. There are many, many queer people. I think here we don't know who's staying quiet. We never assume. But yes, there are stakeholders involved. What I do wish to see, though, is simply that people not assuming. Not assuming is, I think, the first step that we take towards a more inclusive world in itself. When it comes to mental health care and practice, as Dr. Kavita was saying directly, right? Like you end up at so many different spaces. You go to the podiatrist, I don't know, the podiatrist, you end up at like the psychiatrist, you end up at 5 different places. Intersectionality and interdisciplinary approaches shall form the cornerstone of holistic medicine, of accessible medicine, of accessible mental health care. And I think that is the future I aspire to and hope to take a little dip in and, put my little bits in also. That's it, baby.
Thank you so much for that, Kenny. And it is with a very heavy heart that we have come to the end of, I have to tell you guys that we've come to the end of today's webinar. But if you have any questions for our wonderful panelists, you can always, email them to us and we'll be sure to forward the questions over. I think, Yashika, we can move forward.
Thank you so much to our esteemed panelists for taking out their time and giving us insight of all their wisdom. We extend our heartfelt gratitude to Dr. Kavita Arora Dr. Harikirtan Raghuram, Dr. Prachi Patil, and Ms. Kenny Bhatia for their invaluable contribution and for sharing their expertise. Their insight has significantly deepened our understanding of the unequally vulnerable position of the community and their unaddressed needs. A special appreciation goes to our EB members for their unwavering support in this campaign. Thank you, everyone, for joining us today and for being part of this webinar series of our campaign, Rainbow Web. I hope you all have a wonderful night, and thank you so much.
One last note, we will be posting the post-event form right here in the chat. Please do not leave without opening the form and filling it up. At least just access the form before you leave this chat. It is necessary for certification of this campaign. And yes, that's all we'd like to add.
Also,
Yeah.
please turn on your camera so that we can
For
take
a picture. For a picture.
Yeah.
I think we can wait for, 25 seconds for everybody to open the camera. And the post-event form has been shared in the chat. Please fill it as soon as you possibly can. Yeah, so just waiting for everyone to turn on their cameras.
Shambhavi, will you be taking the picture, please?
I see more cameras being turned on as soon as I get ready to take a photograph. But I think let's just wait for 5 more seconds and then I'll take a photo. Do we want to smile? Do we want to say cheese? What do we want to do? Hearts? We can do hearts. Okay, 3, 2, 1. That's a good photo. Do we want to do something else? We can do, let's just take one normal photo. I think the executive board would appreciate that. Okay, yeah, so that's it. Thank you so much for all our panelists. Again, thank you. It has been a wonderful experience hearing you speak. And we look forward to, interacting with you again in the future. And for all our participants, it was amazing having you as an audience. You were wonderful. Again, just a reminder, if you have any questions, please feel free to reach out. We'll forward them to the respective panelists. And please remember to fill the post-event form.
Thank you, everyone. Bye.
Thank you, sir. Thank you, ma'am. Thanks, Kenny. Thanks, Prachi. Thanks for joining us. Bye.